Okay, hi everybody. I know a lot of you know me, but I'm Colleen Capsawala Doyle from the Colorado Department of Public Health and Environment and facilitate our Plains to Peaks regional network. Today, Barbara Gabella is going to be doing a brief presentation on the injury indicators. I'll let her talk about that in a couple minutes, but we wanted to start off with introductions and if you could introduce your name, where you work and your role, and if you have any responsibilities related to analyzing injury data, that would just be helpful for Barbara to know. So I think I might go through the participant list and call on people to introduce themselves, and then hopefully I won't miss anyone. What's nice, I think, now about us working remotely is that everybody's name is on Zoom now. I don't have to worry about phone numbers. So that's new, I think, from last time we've met. So Barbara, do you want to introduce yourself first?
Yes, I'm an epidemiologist in the Violence and Injury Prevention Mental Health Promotion branch. And then I should disclose that I'm currently on the executive board of the Council of State and Territorial Epidemiologists, who did this collaborative work to create the toolkit. But for CSTE, as we call it, I represent substance use and mental health, not injury.
Thanks. Next, Sherry, would you go ahead?
Hi, I'm Sherry Sage. I'm with the Kansas Department of Health and Environment. I'm the state coordinator for Safe Kids Kansas.
Thanks, Sherry. Next, Christine.
Hi, Christine Dumont. Work with the Colorado Department of Public Health and Environment. Barbara is my supervisor, so she knows a lot about me. And I'm an injury epidemiologist. Thanks.
Thanks.
And she just got back from biking to the top of several mountain passes, so.
That's really cool. Next, Deanna.
I'm Deanna Farrell, an epidemiologist in Utah, and I do work on the core SPIP grant and then also work with our violence topics.
Thank you. Next, Gary.
I'm Gary Maurer with the Utah Department of Health in the Violence and Injury Prevention Program, and I am the epidemiology manager.
Thanks, Gary. Jeannie.
Jeannie Beets, Nebraska Department of Public Health, Injury Prevention, and I'm typically the end user of the data after all the magic happens before that.
Thanks, Jeannie. Jeffrey. Jeffrey, if you're on and can hear us, would you mind introducing yourself? Okay.
I don't know where Jeff is, but he's my colleague.
Okay.
Can you introduce him for us, for him, or for us, or for me?
Right, Jeff coordinates the Kansas Violent Death Reporting System. So KVDRS.
Thanks for sharing that.
Sure.
Let's see. I lost my list. Kate.
Hi, Kate Jankowski. I'm at the Colorado Department of Public Health and Environment, and I have the pleasure of working with Barbara and Colleen and Christine. And I'm also a data end user, so I really appreciate all the magic that happens with our EBIs.
Thanks, Kate. And Leisha?
Sorry, I had to unmute. This is Leisha Peterson with Missouri Department of Health and Senior Services, and I'm the Injury Prevention Coordinator.
Thanks, Leisha. Next, Matt.
Hi, I'm Matt. I'm Injury Prevention Coordinator in South Dakota and manage the NVDRS grant.
Thanks. And then Maureen.
Hi everybody, my name is Maureen Ward. I'm the Injury Prevention Program Manager for Montana Department of Public Health and Human Services and also oversee the Overdose Data to Action grant team.
Oh, thanks. And Peg.
Hi, my name is Peg O.G. Ginsburg. I'm the Injury Prevention Program Manager in Nebraska, and I know enough about data to be dangerous with it. I would say yes, I'm an end user.
Cool, thanks. And Sarah?
I'm Sarah. I'm a new injury epidemiology fellow at Colorado Department of Public Health and Environment, and Barbara and Christine are both my mentors.
Thanks, Sarah. And Tracy?
Hi, I'm Tracy Hardy from CDC. I am the former project officer for OD2A for Montana, South Dakota, and Colorado. And I'm also a Barbara groupie, so that's why I'm here.
Thanks, Tracy.
It's mutual, Tracy.
And then I think the only other person that I missed maybe was Allie, but you know, if I...
Everyone, I'm Allie. I work at CDPHE on a couple of different marijuana-funded projects, and I'm definitely an end user. And my favorite thing about working with epidemiologists is when they help me ask smarter questions of the data. It's like just my favorite interaction when there's pushback, and it's like, but what do you really want to know? What if you asked it this way? So.
I actually just noticed Pat joined as well. So Pat, if you mind introducing yourself.
Good afternoon, this is Pat Simmons. I'm the Bureau Chief for Community Health and Wellness at Missouri Department of Health and Senior Services. And I would also consider myself an end user for data.
Okay, great. Thanks. Did I miss anybody? Is anybody else on that didn't introduce themselves yet? Okay. I think that's everybody. Oh, it looks like there's a chat. Jeff said he doesn't have a microphone, so apologize for that, but that's okay. Sounds like he can hear us. Okay, Barbara, I'll let you take it away and I'll monitor the chat.
Thank you. So I'm going to minimize all your lovely faces. And I am so glad that some of us work directly with data and some of us use data, because I do not believe in data for data's sake. It really needs to be practical, actionable results. So I'm really glad that we have this group today. And, you know, when I was putting some of these slides together on Friday, I was in a mood and I was like, well, you know, why would this group want to know about it? Well, you may have hired an epidemiologist, or maybe you have someone who analyzes general injury, but hasn't worked much with the drug codes in some of the databases or data sources that we use. Or maybe you have a new intern, or, you know, so there's I think some different scenarios in which you might want to know about the toolkit. And let me warm up my computer. Okay. First of all, let me back up. Can you see my screen with the title slide?
We were able to see it, but we just lost it, Barbara.
Yeah,
okay. It kind of froze and wouldn't let me advance. So let's see if we can do it now.
There it is.
Yes.
Okay.
See it again.
All right, but it is not letting me advance. And I practiced this right before. You know, it's kind of like when you have a pet and you want them to do their favorite trick in front of an audience and it never works. Or, so let me try this again.
That's really odd.
Yeah, it is. Let me make sure I'm still host.
Yeah, maybe
I logged in as host.
Yeah, it says on the participant list you're host.
Okay. Then maybe I need to do it.
Ah, no, there it goes.
All right. So I will say that Zoom still has black box features for me. So for those of you who think that data analysis is a black box, I'm right there with you. All right. So really, I think that the CSTE injury surveillance method toolkit is kind of the answer for those situations when maybe the structure of the data source that we're using has changed. Maybe we have new staff or an intern. There are a lot of examples in which you might want to visit and look at this resource. I'm going to give you an overview using CSTE slides. Then I'm going to give you an example, and then there'll be plenty of time for question and answer. You are welcome to put questions in the chat box as you think of them. I also have 3 discussion questions that might be of interest to this group. So when you get the slide set, you'll want to use this slide to actually go out to the toolkit on the web. And you can see that it's organized in sections, and you can click on those sections and go right to the information that you want. And I actually kind of think of this as a table of contents on steroids. So when you click on something like data quality, it will pull up a new web page with some new resources to click on. To give you some general background about injury surveillance work, typically injury epidemiologists analyze existing data sets to describe the burden of injury and to inform prevention. And that's really the goal, is to inform primary prevention of injuries. If you applied for CDC funding in the last round, you know in order to be eligible to apply, you as a public health agency needed to demonstrate that you have used 3 data sources for injury surveillance: death certificates, hospital discharges, and emergency department visits. And again, commonly, hospital discharges and emergency department visits are billing data sets. And that means that they're coded in the International Classification of Diseases. Effective October 1st, 2015, billing data became coded in ICD-10-CM. And this change was really a major expansion and revision of the previous code set. In particular, the injury diagnosis codes in ICD-10-CM are over 43,000 codes in number. So that's an increase from over 2,000 codes in ICD-9-CM to 43,000. So you can imagine that there's a lot of change and a need to have a toolkit like this. Some background on the toolkit itself. This is a collaboration between CSTE, CDC, and members of CSTE. And again, these members can be from a state, a local health department, a tribal organization, or a territory. This collaboration began in 2018. If you're interested in older resources, included in the slide deck is a link to that information. The toolkit focuses on injury surveillance using ICD-10-CM codes. And it's designed to be a living document so that we can continually update it with best practices and new resources. And I think that's also why it is a table of contents on steroids, because it makes it easy to update. The purpose of the toolkit is to provide standardized injury surveillance guidance to epidemiologists. And in particular, we want to measure injury morbidity using these ICD-10-CM coded data sets that tell us about hospitalizations and ED visits that might be related to injury. The toolkit provides standardized validation data sets to test analysis code on fictional data with a known answer. And I'll come back to this. The toolkit also provides key differences between hospitalization and ED visit data that helps us make proper interpretations when we analyze this data and look at our results. It also shows how to report standardized injury and overdose indicators, recommendations for data presentation and visualization, and a glossary of concepts and terms. So again, here are the same sections showing you some of the information within the sections. Again, that's why I call this a table of contents on steroids. So the homepage gives you an overview and the purpose, which I've already highlighted. The introduction is really a primer for new injury epidemiologists. The injury reporting framework is still under construction. So I added a link to one of the source documents that will be used to update this section. There is a section on surveillance case definitions, data quality, data presentation, programming resources, and here's where I want to talk about standardized validation data sets. So as a data analyst, I am using ICD-10 CM coded data. So these are billing data. They weren't created for injury surveillance. They were created to pay hospitals for medical treatment. And so this standardized validation data set is really helpful because I'm going to use a statistical software. I happen to use SAS. Other people will be using R or SPSS. And I'm going to write code to analyze my Colorado hospital data. But I get some answer. Let's say I want to just simply count injuries from all hospitalizations for all causes. How do I know this number is right? How do I know that my SAS code was correct in identifying injuries? And so what's cool is I can take my stat program, my SAS code, and run it against one of the validation data sets. And we know in that data set how many injury hospitalizations there are. So when my SAS code tells me that there are 10,000 injury hospitalizations in this Colorado hospital data set, and then I check against the known answer, and it says, no, there's 9,500. I know that there's a problem in my SAS code. So I think this is one of the most valuable pieces of this toolkit. You know, we want to know the right answer, and this helps us know if we got the right answer. And then, as Colleen mentioned, there's information on injury indicators. They're organized first by general injury indicators, which are really very similar in terms of meaning or focus or topic as the previous injury indicators under ICD-9 CM. And then there's drug overdose indicators because there's some special considerations for that. And then there are some new or exploratory indicators. Christine is on one of those CST work groups looking at some specific indicators related to motor vehicle related injuries. And you'll see at the bottom there, coming soon, are special emphasis reports. And those, the first three are going to focus on suicide, motor vehicle related injuries, and traumatic brain injury. And what they are is they're a template with graphs, pictures, and draft text. And then you in your jurisdiction can analyze your data and plug in your results, and you'll quickly have a 2-page summary related to suicide in your jurisdiction, or TBI, traumatic brain injury, or motor vehicle related injuries. So look for that. Because it is a living document, we already have identified some changes coming in the future. There'll be a recommended citation. CSTE is going to revise the formatting of the glossary and add new terms. Eventually, there'll be links to the CDC products, And as I mentioned, there'll be a new section on injury special emphasis reports, and also a new section on using syndromic surveillance data for injury. And for those of you who don't know what syndromic surveillance is, that is rapid information on chief complaints from emergency department visits. It was originally created after 9/11 for bioterrorism and other types of environmental exposure. CSTE would like me to acknowledge that this work was funded by CDC, and then I added Mia Israel contact information in case you want to join one of the injury work groups. So here's an example that I wanted to show you about the toolkit. So if you were to click on the section Data Quality, then you'd see a link to this document, Special Considerations for Drug Poisoning ICD-10 codes. And then if you click on that, you'll see that it's organized by issue, and that it talks about the issue or the impact of the issue, and then how to assess if this data quality issue exists in the data set that you're using that's coded in ICD-10-CM. And I just pulled out 3 examples of issues. One is that it's not always the same character in the code that indicates intent. So imagine if you're trying to do SAS programming or statistical programming, you need to make sure that if you want to know the intent of the injury, unintentional, intentional, and so on, you need to be sure that you're looking at the right character for the right code among those 43,000 codes. So it's daunting. If you want to look at the, if you want to estimate drug overdose, then it's important to know the number of drug overdose T codes in each record so that you interpret your results correctly. And so there's some guidance to see if, to assess if there's any issues related to this and how you would look at that. And then there are adverse events and adverse effects related to drugs. And so again, typically we do not include those in drug overdose, but it's not a topic that we see much information on unless you have been a clinician and or a prescriber. So that's important for injury epidemiologists to know about. Unrelated, I wanted you to know about an upcoming resource. There's going to be a special issue of the Injury Prevention Journal on ICD-10-CM and injury analysis. And what's nice about this international journal is it's open access. And so if the lead author pays for open access, then anyone can get a copy of the full text article, which is really nice. And that's the end of my presentation. Here are the discussion questions. Colleen, is there anything in the chat that I should address?
Nothing in the chat, but do you want to take questions first or do the discussion questions?
I'll take questions. I can go back. Does anyone have any questions? I think it's one of those things, until you need it, you won't really dive into it, if that makes sense.
Mm-hmm.
I think the other value is it kind of gives you a preview of what we're expecting from CDC for the future CDC injury indicators. So if you want to, get ahead of the game, you could use the toolkit to calculate those general injury indicators now, rather than waiting for that information to come out of CDC.
Can I ask you a related, unrelated question, like sort of related?
Yes.
Question? I'm just, you know, given the recent news about data from hospitals being reported directly to HHS instead of CDC because of COVID-19, will that have any trickle-down impacts on injury data, do you think?
No, not the way it's being implemented now.
Okay.
Yeah, it kind of reminds me to tell you that these ICD coded billing data sets for hospitalization and ED visits are not standardized across states. And again, they reflect a bill that's going to the federal government for payment, like to Medicaid or Medicare, or to health plans. And there is a standardized billing form for Medicaid and Medicare, so for federal government payers. But your agency could get some of that information that's on the standardized billing form, or might get a subset or a collapsed set of information from it. So in that regard, it can be challenging. And so another way of saying that is that we are getting information from our Colorado Hospital Association, and they're getting it directly from the hospitals. And these are bills for all medical care. So that shouldn't affect us, just the fact that people working on the COVID response had been reporting to CDC through one data pipeline, and now they're reporting that information on COVID to another data pipeline that bypasses CDC and goes directly to HHS and the White House. Is that clear?
Yeah, thank you. That helps.
Yeah. Now I'm going to I'll put on my CSTE hat. CSTE has been working with the Association of Public Health Labs, with the private association that represents the electronic health record industry. So for those companies that write that software and sell that software. And I am forgetting the fourth organization. And so they've been talking about talking to people in Congress. This was like a year and a half ago, about the need for money to bring our data infrastructure into the 21st century. And that campaign you can see on the CSTE website also, and the progress they've made. That campaign is called Data is Elemental, and COVID is just highlighting that. People working on the response in Colorado are doing so many things manually. And what IT systems are in place are all patchwork and weren't created with public health action in mind. And that's one of the differences about Data is Elemental. So Congress actually included one-year funding of $50 million back in October. And CDC was working to get that money out to states and local jurisdictions, to public health, but then COVID hit. And COVID, I think, is just showing that, we don't have a good infrastructure for reporting locally to state to CDC. So I'm curious, we've heard a few people on the call today work with the National Violent Death Reporting System. Are there other data sources that your state uses to inform injury prevention? You can either put it in the chat or unmute yourself and share to the whole group.
In Nebraska, we have our system still set up for CODES, Crash Outcome Data Evaluation System. So that's primarily what I'm familiar with, and using hospital discharge data, ER data, death certificate data, police records, DMV, all of those coming into one central location and kind of creating a bigger picture of what we're seeing out there. So that's what I'm most familiar with.
That's right. I think Utah used to be a code state. So have you been able to sustain that, given that there's little funding for codes?
Luckily, we did sustain it. Our DOT kept it. We never stopped doing it when it was first funded. So we've had it ever since. I think I'm not sure when that all started. That was before I was working there, but luckily they felt it was important enough to keep that running for data sources and things. So we've always had it.
And in a way, it's like NVDRS, only focused on motor vehicle safety and motor vehicle related health outcomes, right?
Yeah. Mm-hmm.
Multiple data sources being compiled together, both manually and electronically.
Yeah.
And then I see Ali mention our Healthy Kids Colorado survey, which is the YRBS plus more schools, more questions. Any other data sources?
We also use YRBS and then also the BRFSS as well for adults.
Another thing that's we're using because you can get more current data is syndromic surveillance.
Okay. And you've been using it for injury or drug overdose or both?
Well, we've been using it mostly for injury, especially related to like suicide.
Yes.
Related information.
Are you one of the 6 states that CDC funded to use syndromic surveillance for suicidal outcomes like suicidal ideation, suicide attempts?
We are, and we've also been using it for opioids and our kind of drug overdose.
Yeah, if people are interested, I think it would be great to have some of the states that are working on suicidal outcomes in syndromic surveillance data to present on one of these future calls. I don't know the right timing, so you might know the right timing. Was it Greg or Gregory?
That was Gary.
Gary, oh, I got your first initial right. I have you guys minimized, so when you're not talking, I don't see your name. No offense, I just have a lot going on my little laptop.
No problem. I've been called that before, and I've been called worse, so no problem.
Okay. Yeah, I've been called Hey You, and I've also been called Eric's mom. Come over here.
I like that idea, Barbara, of the suicidal outcomes and syndromic surveillance. So I'll put a note, in my running list of learning opportunity ideas, and we can brainstorm who would be best to, in which states would be best to present on something like that.
Yeah, and I think it's one of those things where even whether it's feasible and lessons learned is of value for, at least for me to hear. It doesn't have to just be results, here are the results, but is it feasible for other states as well? Well, hearing silence in the chat box and via microphone, I'm also curious. Oh yes, Christine mentioned crash reports. So again, anyone doing codes probably uses crash reports as one of the backbones to that system. It's Christine's job to analyze the crash reports for injury surveillance in Colorado. So I'm also curious to hear about data challenges and successes. So what data challenges could this network or learning group and CSTE and/or CDC address? Any burning challenges that you want to bring up? for those of you who've heard me speak before about data, sometimes I share that, bad data are expensive, good data are even more expensive. And so, I just think anything that we can do to ensure that that our use of these existing data sets are useful to people who are conducting injury prevention, that we need to work on this together. And the sooner that we can have that collaboration, I think the better. So I appreciate this opportunity to talk with you guys. Oh, I'm not supposed to say you guys. That's one of my personal changes I'm trying to make. I've been in Colorado a while, and that's when I picked it up. I never used you guys when I lived in the South.
I
was
have
trying to say something.
A thought or question just about, sorry, my phone's going off. Just a sec. I got to check it.
Okay. Any successes while we're waiting for Deanna?
This is Sherry with Safe Kids Kansas, and our injury epidemiologist, on about a 3-year cycle, we'll have her create a comprehensive childhood injury document that really reflects what the burden of injury is on children. And we look at that, we're looking at death data as well as emergency department and hospital discharge, so we break those down. We also break that down by trauma region, so we look at what the trends are statewide and then as well as regional. And we have about 30 local Safe Kids coalitions across the state as well. So this is something we can do to help them. Some of them are in rural counties and would need to be drilling down, probably no smaller than their trauma region anyway. But it helps them to look at what injury risk areas that they should be considering as part of their planning. It can also help them with policymakers, local decision makers, and it can also help them to write grants. It gives them some data that they can use that's as localized as that they can probably get. So that's one of the things we're able to do, is producing this document. We reference them regularly, and our EPI is working on the latest one that will be, like I said, we only do this about every 3 years, but she's working on one currently to release here in 2020.
That's a great example of a success, as well as hidden in there was a data challenge, which is one that occurs in Colorado too, and probably many of the states represented on this call, which is sometimes we cannot provide local data or as small a geography as people want or request, and that we sometimes have to regionalize the results for 2 reasons: to protect confidentiality and for statistical reliability. Otherwise, you'll see, results from period to period. If you're looking at a short time frame, like a year, jump up and down, and that's just not helpful if it's really an issue related to small numbers. Any other challenges or successes?
This is a challenge, but maybe it's an evaluation challenge related to data. I know this is something you and I have talked about before in the past, Barbara, and I'm curious others' thoughts. But when I think about the core state violence and injury prevention program grant, one of the key strategies is around surveillance and data dissemination. And I think one of the challenges we have is really evaluating dissemination of data, and whether it's getting into the hands and on the desks of the people that we intend it to, and how it's being used. And I'm curious if others have ideas on how they've evaluated that, or if they have, because I think it's an area that we sometimes struggle in Colorado.
Yeah, I would agree that's a challenge. Again, I said, you know, I only want data for action and data that's useful to the actors, and it's hard to get that feedback up front and after we disseminate any kind of data product. It can be a dashboard, two-page brief, it can be like the child injury report we heard about that is done every 3 years. It doesn't matter, it can be hard to get that kind of feedback.
And thanks for bringing that up, Colleen, because as you know, we're going to be putting together Injury in Colorado dashboard. And I'm curious if other states have injury dashboards. And if so, have you done away with actual reports or briefs, or are you doing them together? I'm curious what other states are doing to disseminate data.
Christine, this is Deanna in Utah. We don't have a data dashboard at all. We still do use IBIS that's connected to our hospitalization, ED, death data, NVDRS, a bunch of different data sources. But it's not as smooth and savvy as a lot of the newer dashboards out there. So we still do a lot of fact sheets and reports for our data dissemination. I know some of our grants like opioid have started to move some topical areas to dashboards, but our injury data has not gone that way yet.
Thanks, Deanna.
We're
We're happy to share ours when we get it up and running. Just COVID has kind of deployed some of our staff, including myself, from getting that up and running. But
yeah, I would say that it's, you know, my bias is it's not either or, that we still need some of these one-page talking points from the dashboard anytime we update a dashboard. So what's changed, what's gotten better, what's gotten worse, unless the dashboard is set up to really highlight that from the get-go. We just updated, not me personally, but the health department just updated the our drug overdose dashboard, and immediately it got the announcement that it was updated went viral in Colorado. So I really got a lot of questions, including, do you have a blog post somewhere that highlights the main talking points? Because we want to distribute those as well. And if you were to go to that dashboard, like I get overwhelmed. There is so much data and so many different ways that you can cut that data, so to speak, that it is hard to make sense of what's changing, what's going in the right direction, what's stalled, what's going in the wrong direction. So I actually am looking forward to these special emphasis reports. I also think of them as kind of Mad Libs, meaning that we would probably put a blank template up with the injury dashboard so a local can download it and add local results by using the dashboard. We'll see if that helps. It could be an idea on paper that looks really feasible and helpful, but in reality, goes back to Colleen's question, how do we get real world information from data users that this is helpful? So I noticed the time, Colleen. If there aren't any other comments, do you want to take over?
Sure. Are there any other final questions or thoughts?
I did just want to loop back. Sorry, I jumped off earlier on the phone call. I was just thinking, I know that, so for, ICD-10-CM data to work, we really need hospitals to be coding injury data correctly. Is there work being done through CSTE or CDC to help hospitals code things better to ensure that those codes are there for us to analyze?
Yeah, unfortunately, I have a lot of thoughts. First, I will say that it's really helpful if your state has a chapter of the Health Information Management Association. Colorado does, and they have created for Colorado kind of a tip sheet for injuries. Also, a lot of hospitals have a quality improvement committee related to coding, and they try to get a physician champion in that hospital to help make those kinds of improvement. And that is because almost all of the codes, not every single code, but almost all of the codes, you need physician documentation in order for a professional medical coder to follow the ICD-10-CM rules and assign a code. And so that happens, that kind of work happens, at least in Colorado, at the hospital level. And I'm happy to send you what our Colorado Health Information Management Association put together.
That would be
I think
great.
it's an ongoing issue. It's also why it can be difficult at times to look at new, like, subtopics in injury and know what it really means.
That would be great, Barbara. Thank you.
Yes. Yeah, so we work a lot with the data analytics team at our Colorado Hospital Association and with our Colorado Health Information Management Association, at least in terms of improving coding. And if we do any assessment of the quality of coding, they are so open for us to present on that. Any other questions? Well, thank you so much. And I am also open to feedback or ongoing dialogue one-on-one, so feel free to email me. I think that's my last slide technically. So let me get to my slide.
Yeah, thank you so much, Barbara, for the presentation and the discussion, and for the ideas on future learning opportunities as well.
Sure.
I don't have any other formal announcements. If there's anything, any questions, or if people have ideas on or requests for future learning opportunities, our next one is scheduled for September. Usually in September, it's when we have our in-person meeting at the annual Safe States Alliance conference, but that conference is going to be virtual this year. And so I'm going to follow up with Safe States to see if they're going to hold time and space for a connection for the regional networks. But if not, I will get something on the calendar for September. And if people have requests for learning opportunity ideas, please let me know. There's nothing else, we can end a few minutes early. Okay, well, thank you everybody for joining today. And thank you again, Barbara, for the presentation facilitation.
Yeah, this is my Zoom wave. If we were at a conference, I'd never be waving like this at you.
I like it.
And it's nice seeing some of the people I already know, and it's nice meeting new people. So thank you so much for attending.
Yeah, thanks. And I'm hoping that the recording works, and I'll get that posted on our website, and I'll share out Barbara's slides as well. Okay, everybody, thank you very much.
Thank you. Bye.
Bye.